Okay, well, I pretty much know half of the people here anyway. I'm Bartlett, and I'm on the Hartford Dismas House Council. The most exciting thing about Hartford Dismas House this year is that we're celebrating our 10th year being right down the street here in Hartford, which makes me really happy because we've literally been able to help hundreds of people in the transition out of incarceration and back into the community. And we've had thousands of people come in and have dinner with people who live at the house. And with me is Tom Grillo, who's the director of the Hartford Dismas House, Wendy John, who's also a transition coordinator at the house, and let me see. One of the most important things about this speaker series is that we want to thank the community for all the support that they've given us and to help the community understand some of the issues that people who live with us go through every single day. And the hard work that they're doing to do that. And one of the people who helps enormously is Will Eberle, who runs a program called Recovery Vermont. He's going to tell you about it. But one thing that I find so amazing is that he has trained 600 people here in Vermont to be recovery coaches, and sort of this notion of peer-to-peer, you know, of your friends and your colleagues and the people that you know who've gone through what you're going through, helping you, is just so core and fundamental that I think is part of this incredible success that you've been having. And I'm so glad that you're here to talk to us all today. And I'm going to shut up now and I'm going to hand the mic over. Maybe. There we go.
Thank you.
Yeah.
Thank you for the kind words and the introduction. My name is Will Eberle. I'm the Executive Director of the Vermont Association of Mental Health and Addiction Recovery, aka Recovery Vermont. I really shouldn't be standing here today. I really shouldn't be alive today. And before we get into the work that we do, it's helpful to kind of understand some of the motivations and some of what that journey looks like. So I'll take just a moment and kind of talk about that just a little bit. So I grew up in a town way in the northern regions of the Idaho Panhandle, right on the border of British Columbia, in pretty abject poverty initially as a child. So initially as a child, my first experiences of home were to be traveling in a school bus with 30 or 40 people traveling around the country and parking where you could and eating what you could find. And eventually migrating to a place called the Cedar Cabin, which was essentially what you would probably call a shack in the woods. Went down the cliff to the bottom of the valley to this little creek and hauled the water up with buckets, and had a wood stove in the corner, and we'd cook the food on tin foil and things like that. And if you were to walk upstairs on the top of the loft, the building would move to one side. And if you moved it the other way, it would move to the other side. And if you wanted to see what was going on outside, you didn't have to open any windows. You could just look out the cracks in the wall, and there wasn't really much to do there. So that experience was really kind of the formation of a lot of trouble that I had throughout my life with mental health challenges, with addiction, with homelessness, with unemployment, with those types of things. So from a very early childhood age, I was really in an environment surrounded by people misusing substances and really not providing much pro-social engagement or support or modeling, and we didn't have a lot of things to do in the protective factors column. So I ended up going through a lot of those types of experiences, all the things that we would now call ACEs, a lot of childhood trauma, a lot of those types of things, and eventually got alienated enough to drop out of high school and run away from home when I was about 17 years old. So I spent quite a bit of time after that in my early adulthood really just trying to survive, flying signs to get enough money to eat, sleeping under bridges, on cardboard, riding freight trains, getting different entry-level jobs, losing them quickly, those types of things. So I spent a number of years really suffering from mental health challenges and responding to a lot of that with utilization of substances really as a way of kind of managing those things, which quickly turned into substance use disorder that was really not in my own control. I had a certain time in my life where I realized that I wasn't making the kind of impact that I wanted to make, and I wasn't able to do the types of things that I wanted to do. Up until that point in my life, it had really been about survival and about what are those jobs that you can get with the education and experiences that I had. So having dropped out of high school and growing up in a really remote area and not having a lot of those experiences, the types of jobs that I could have so far in my life were like highway flagger, logger, dishwasher, mason tender, roofer, construction person, dishwasher, prep cook, diner, waiter, those types of things. So I kind of did every single one of those types of things that you can imagine. Gas station attendant, the resume looks really weird until you get to the certain point where I ended up living in Vermont. And it was kind of a convoluted journey. Initially, I had an opportunity to work with a builder who was just an incredible mentor. And he taught me how to do carpentry, but he also provided me just a lot of stabilization and support in my life. And through that process, I learned enough skills to really kind of start my own business as a carpenter and have enough money to really kind of be economically independent. But right away, I also had a really debilitating injury working on a job that ended up making me totally unable to walk for like a whole week. So I ruptured a disc in my back. One day we're on a job moving around these huge beams and building this timber frame and everything's great. The next day, you can't walk, you can't get out of bed, you can't do anything. And at that point in my life, I realized that I didn't really have an exit strategy other than just doing any possible thing I could do for the rest of my life. And it really hadn't gone so hot so far. It had been really a tough thing. And I really didn't want to end up having to still do construction past the point that my body was able to do that with a lot of chronic pain and injuries and stuff that I was dealing with. So I thought I really have to do something else. But I was really intimidated because I hadn't yet really had any formal education or training or anything like that. So I had just met a person who is now my wife who encouraged me to go back to school. And I thought that was not a good idea. I totally struggled in school. I had a learning disability. I failed algebra like 3 times. I dropped out. And, the tests did not go so hot, those types of things. So I was like, what are you talking about? That sounds like the worst plan ever. But I decided, I don't really have any other ideas. Might as well give it a shot. And ran into a person who totally changed my life, who handed me something called a VSAC scholarship booklet and said, they have these things called scholarships, and I know you really don't have enough money to go to school more than just this first semester you're doing at CCV, but they actually have this way that you can pay to go to school based on merit and need and all these other things. So she helped me do the FAFSA. And she circled 12 scholarships she thought I was eligible for in the booklet. And she said, I want you to write for every single one of these. And I thought, that's a bad plan, but all right, I'll do it. And I got 10 of them.
Oh, nice.
And I was able to completely finish my bachelor's degree without owing any money whatsoever.
Congratulations.
Which,
Yeah.
thank you you so much. And so that really opened the door to all these things that really come next. And so in that process, I finished up with an apprenticeship program for the end of that degree that was really focusing on working with at-risk youth, going through a lot of the same types of things that I had been through. And in that process, I was teaching people how to do carpentry, ironically, even though I was no longer really hoping to do that. I was teaching them vocational training skills and job readiness and how to use a Sawzall and a nail gun and all those types of things. And that was interesting, but what was more interesting to me was that when you were sitting there working with a person and you weren't looking at each other and one person is nailing something up and someone else is cutting something, suddenly people just start talking about their lives and about everything that they're dealing with and what's going on with them and what would be helpful and what they need. And I thought, that's what I actually really want to do. That's super interesting to me. So I thought, that's a ways off. I don't really know how to do that yet. I've got to get some degrees and some licenses and some certifications. It's going to take forever. It's hard enough just to get this bachelor's degree. So anyway, I kind of forgot about it for a minute and went back to finishing up this apprenticeship I had to do to finish up that degree. And one day I'm sitting at my desk at the Youth Services Bureau of Montpelier and reading the local paper. And there's an obituary. And in that obituary, there were like 3 of the students that I had been working with in that vocational training program who had all died horribly in different ways related to addiction. And it just totally broke my heart. And I saw that there was a common theme with some of them, that they had engaged with this place called Another Way, which was a community center in Montpelier. And I had never heard of that. I didn't know what that might be. I thought it was kind of interesting that that had been important to all of them. So I thought, why don't I just pay my respects? So I went over there and popped in and just kind of had one of those like lightning bolt moments where I'm like, what is this place? This is incredible. And there was a community kitchen and meals, and there was a karaoke thing happening, and some other people were talking about a recovery-based bike camping trip, and other people were helping each other get jobs. And it seemed like some people worked there and some people were like getting help, but you really couldn't tell who was who. And I thought, you know, that's kind of the place for me. And yet here I am finishing this internship at this other position, doing this degree, whatever. But there just happened to be a job opening that came up within like a week of that for a peer support counselor. And I didn't know what a peer support counselor was, or what peer support was, or how any of that worked, but it sounded pretty cool. So I met with the director and interviewed, and you know, at first I was worried that all of these barriers that I'd had in my life were going to stop me from being able to get a job like that. You know, oh man, I've been homeless, I've dealt with addiction, I've dealt with, you know, being a high school dropout, I've dealt with being, you know, moved out of towns by police and this and that. And, you know, if I really start to kind of tell you what my last, you know, decade of life looks like, you're going to say, forget about it. But, you know, I got to talking with him before the interview just kind of about what they did, and I realized that actually each of those things were qualifications for me to do this job well, and that was like the essential functions of the job. And in any other job, that would be like, do not pass go, don't, you know, no $200, forget about it. So suddenly I realized that there's this thing called peer support, and that was basically about using the own difficult experiences that you have overcome to connect with other people still going through those things to do a number of things, like save lives, literally, help to connect people to supports around employment, help people get support with, you know, mental health and substance use, and reconnecting with their families, and being appreciated in their community again, and different things like that. And so I was blown away. I couldn't believe this was happening. So I got this job. It was my first actual like job where there's a salary and they paid you a certain amount, and there were like benefits. You had to sign up for health insurance and do all this different stuff, and I just couldn't believe it. And it was amazing. I loved it. I worked with all of these people, and you know, just had incredible experiences there where people had been spending most of their lives in psychiatric facilities or in a series of incarceration stays, or dealing with, you know, being homeless in one encampment for another for 20 years or something like that. And then they would come to the center, and suddenly, it wouldn't happen overnight, but they'd slowly get the message that people really cared about them, they were welcome there, they had a place there, and there was this whole suite of services that was available. And over time, people would gain confidence and comfort and start to engage with supports. And it wouldn't always work, but often people would get jobs or reclaim connection to their kids, or go to treatment and find recovery, or any of those number of things. And more importantly, there's a place that was sort of a home base. If you're playing tag and you run around and you can touch this place and you're safe, it's the same thing for them. And in a hostile world where there weren't a lot of people in their corner, there was a place that they could go and knew that that was their spot and they were safe. And we kept a lot of people alive and changed a lot of lives for a lot of years. And it was really exciting. I did that for about 3 months. And then the director got $1 million to go and start the Soteria House up in Burlington, which is one of 2 programs in the world that can work with youth experiencing first break psychosis in a residential setting with peer supports. And it was amazing, but that also meant that there was a vacancy to be the executive director of that center. And so I thought, well, I've had a lot of luck applying for jobs that I don't understand or really feel qualified for, you know, here so far. Maybe I should just kind of keep this thing going, you know, snake eyes, snake eyes, snake eyes. And they gave me a shot as a person who really had no executive experience to speak of whatsoever. And that was sort of the next door that opened for me, and it was a total life-changing thing. So I got to be the lead implementer of something called the SAMHSA Mental Health Transformation Grant. 16 in the country, we had 2 in Vermont, led the demonstration of that, helped to replicate that up in Burlington. And then through that work, got tapped to be like a national consultant for something called the Brass Tacks Technical Assistance Entity. So trained nationally to help states all around the country learn how to do what we're doing right in Montpelier, Vermont. And what that was literally just talking with people in a way that actually said, you know what, I don't care about any of that stuff that happened up to this moment. I want you to know that when you walk through this door, you get a new start, and we actually do care about you, and every single person who works here has been through those same things. Probably not the exact same things, but similar enough things to really have some empathy and some deep understanding with all of that. And you're in the driver's seat here. You know, we have this huge menu of opportunities for you, and that's only going to be helpful when you show us what you're really trying to do in your life. And we're not going to rush that. If you need to spend 6 months just feeling safe enough to walk through the door and get coffee and know that if you set your backpack in the corner, it's not going to get stolen, and if you tell some other people about your life, they're not going to turn that against you, maybe it's going to take a long time before you finally say, the coffee's been great, but actually I want to go to rehab, or I need job training, or I want to go to school, or whatever it is. So that was amazing. You know, had the opportunity to train nationally, to present at conferences, to meet you know, sister programs all around the country doing similar work, and continue to develop our own innovative models that really combine peer support with supported employment, which are specific supports helping people with some of those background barriers to getting into jobs that are enriching to them, and then climbing the ladder to jobs that they're more excited about over time. And all of a sudden, I had this realization that we were helping a lot of individual people, but it seemed like we were really bumping up against the limits of the system itself. And why did we have to keep kind of Humpty Dumpty in every situation with every single person, one at a time, the same types of things over and over and over? And wouldn't it be better to work inside the system and try to change things inside the system in a larger way? So I heard the siren call of systems change, and took the rudder of the ship and started steering towards the shoals. There was a position called the Agency of Human Services Field Director that became available. And I applied for that, having zero experience with state government or supervisory experience in a rigid governmental hierarchy, or any knowledge of any of the systems at play within the system of the Agency of Human Services, and connected to a person who took a chance on me yet again, who thought I had the right combination of things to be able to do it. And they said, you know what, sure, why don't you handle daily operations for 29 subsidiaries of 6 departments across 2 counties and 1,000 people and 7 buildings, just go for it. And so I thought, okay, sounds good to me, let's do it. And immediately found out how much harder it is to find solutions within a difficult bureaucratic system with a lot of federal and state, you know, parameters around what's possible, than to point at something and say, well, that's wrong. We shouldn't do it that way. That's clearly not working. So I had the opportunity to work for 6 years there. And it was a really rich learning experience. We did a lot of incredible work during COVID, handled the mass feeding sites that fed thousands of people, distributed the personal protective equipment, got called upon to resolve the most difficult cases in the system of care, the things that slipped through the cracks that nobody could solve at a local level or statewide with children or adults, acted as the bridge between the commissioners and the district directors and the state organizations and the community partners and things like that. Started the first homeless shelter in Lemoyle, started the first recovery residence in Lemoyle. You know, lots of things I can look back on that I felt really proud of and really excited by. And I thought I'd be there for a really long time. And, you know, things were going really well. And then I got a call out of the blue from a person over at this place called the Vermont Association of Mental Health and Addiction Recovery. And they said, you know what? We need a new executive director, and we really think that you would just be perfect for what we're looking for. What do you think? And yet again decided, all right, let's keep jumping. Let's leave. Let's try some new stuff. And I've been there for just about 2 years. And that has been incredible. So it is an organization. Now we're talking about Recovery Vermont, the actual alleged topic of the talk you came here today to hear. And For the last 40 years or so, this organization has been really at the spear tip of advocacy in the state for a systems change to really improve the resources that people have who are managing, substance use disorder, dealing with underlying issues around mental health, around incarceration and homelessness and trauma and all those types of things. So before we became VAMHAR, we were VAM, which was the Vermont Association for Mental Health, before addiction recovery was added to the mission. And we succeeded in negotiating for parity for the first time any place in the country, which included the opportunity for the healthcare system to pay for an equal amount of support with mental health as physical health. And then did work to expand the regard for peer-based supports to be moved into the Office of Professional Regulation and to open the billing doors for Medicaid reimbursement. So currently, Vermont is about to be one of the very last states in the country, unfortunately, to have what's called a licensed, a certified mental health peer support specialist, rather. So something like 48 other countries, 48 other states have that. You can be a certified peer support specialist in Iowa or, Idaho or Ohio, or pick a continent, you'll find a state, there it is. And what that means is that there is an accepted scope of practice and a training background, and at the end of the day, you do that job, but the organization you work for can pay for you to do that job because they can hit this button that says Medicaid reimbursement. This is a validated, accepted service delivery mechanism. So we are on the cutting edge of, I would say, an explosion of what the workforce will look like in the next few years in Vermont, as we realize, as our participant in the beginning mentioned, the Certified Community Behavioral Health Center model, CCBHC, that is a model which requires peer support and recovery supports to be baked right into it and provides really robust reimbursement for the same. So at the point that we start to see more of these across Vermont, there will be a requirement to include more of those types of positions and have more mechanisms to pay for that. We also have an opportunity there with the new mobile crisis service delivery system through the designated mental health agencies, which also requires peer support. So what I will tell each of you is that dynamic of, I've been through all these difficult things, I don't know if I really should be able to get this job you're talking about, will suddenly be the essential requirements to get jobs which save lives, transform lives, and are going to be infused, I would say, across many nodes of the system of care, hopefully very soon at a very large scale. At this moment in time, we do have recognition for something called recovery coaches. And historically, that has been a lot of the work that Recovery Vermont has done. As referenced at the top of the hour, we have trained about 600 coaches over the last 10 years or so, and had formed the certification board and provided the certification as well for certified recovery coaching in the state of Vermont, and helped to ensure that that's available in every single county, every recovery center in every county, and every hospital emergency department. So if anyone in the state has an overdose event where they find themselves in an emergency department, part of their exit planning will be to connect to a recovery coach who had been trained by Recovery Vermont. And anyone walking through the door of a recovery center will have that same experience. That's all well and good. We're really proud of it. It's definitely something that we feel a lot of positive connotation for. And yet, there are many, many people who don't walk through the doors, that don't go to recovery centers, that don't find themselves in emergency departments, who are still really struggling with substance use disorder. And substance use disorder itself, I would say, from a place of lived experience, not from a place of being a brain expert that can talk to you about the specific function of the amygdala or the neuroplasticity associated with the hyperfrontal cortex or whatever. But just to say, as a person who's been through the stuff directly, is almost never isolated to just substance use. It's almost always a relatively logical response to a complex stew of life events involving trauma and poverty or abuse or employment or incarceration or family dynamics or whatever. So because of those two reasons, we have decided that we don't want to just keep training recovery coaches and just keep doing recovery coaching the way that it is. We are in the business now of creating a more expansive model that is truly holistic, that is looking at mental health, looking at trauma, looking at poverty, incarceration, violence, all these types of things, to really present a framework that really you can work with globally with people that could help with substance use, that could help with mental health, any of those things, but that will always be able to help with whatever those conditions are in the person that you're working with. And rather than just doing that for people who are recovery coaches in recovery organizations, we would like to make that available to any person that wants to be part of that process, whether or not you're working in an organization or a family member or whatever the case may be. So we're in the process now of redesigning a cutting-edge new training platform on an asynchronous learning platform, which allows you to do a self-directed pace of learning and access these tools in a totally unimaginable level of physical accessibility relative to what our trainings were before. We'll have modules available that you can listen to that are narrated in Vermont's 6 most common languages, Arabic, and French, and Swahili, and Spanish, English, on down the line. There'll be an opportunity to watch ASL, sign language interpretation of these language delivery for all the trainings as well. So it will suddenly be the case where I can't think of a person who wouldn't be able to engage with our trainings that's interested, regardless of what your ability is, your background is, what organization you work in or don't work in, and that won't necessarily have to be limited to the borders of Vermont anymore as well. And so to take the time that it deserves to make sure that those trainings are actually going to serve people in the way that we're hoping, we are doing a tour around the state of listening sessions. We're really getting in-depth engagement and support from people who we feel like we've historically missed. And you've probably heard a lot of acronyms, that people use for this, like BIPOC or LGBTQIA2S+, or things like that. But very simply, if you look at population level health data, it shows you that there are certain communities of Vermonters, and this stands out nationally as well, who are at the greatest risk of dying early, of having an overdose event, of being incarcerated, of being homeless, etc. And that coincides to the experience of being a person of color, being a youth, being an older Vermonter, being gay, lesbian, transgender, etc. The other thing you'll notice is that if you then look at the workforce that we have that's working on these issues relative to those same populations, there is a very low overlap of that diversity represented in the workforce. So if you're a person of color and you're trying to get support around recovery or homelessness or whatever it happens to be, your chances of connecting to another person of color currently are extremely low. If you're a transgender person, exponentially lower, and on down the list. So we're really trying to both make sure that those trainings are meeting the actual needs of those communities by just hearing directly from them about what they would need. But then we're also working to try to aggressively diversify and grow that workforce so that that will actually be the case, that your identity can be reflected in what your care looks like and not just in your own life outside of that care system. So that's what we're up to at this exact moment in time. And part of our work is to develop this and make it available and scale it. Another huge part of the work is to really engage in anti-stigma based work to make it feel safe for the average person to actually talk about substance use challenges, mental health challenges, incarceration, homelessness, any of those types of things. So that, combined with our effort to provide tools for employers through a recovery-friendly workforce initiative to say, you've already got people working for you now. A lot of people are dealing with substance use challenges and underlying conditions that maybe you don't even know about, and here are a series of tools that are available to help you make that easier to sustain the workforce that you already have. Those are really our key activities right now at Recovery Vermont. So I've given you an enormous amount of things to think about and respond to and ask about and decouple and et cetera. And I know that we probably don't have a whole lot of time left, so I'd like to just pause at this moment and turn it into an interactive conversation and give you all the opportunity to ask questions and dig deeper into anything that we've talked about so far.
It's amazing. Just say, you want to say, thank God you are who you are. And then you come as far. It's a beautiful story.
I appreciate it. Thank you. There's one other thing that I should have led with it. I didn't even say that I better fit in there real quick before we go too far, which is another of our key activities right now, something that we call Beyond Bars. And this is a pilot funded by the feds, which allows us to provide peer mentors who have a lived experience of incarceration, homelessness, substance use challenges, etc., that are working directly with people who've been incarcerated once they're back in the community to help stabilize crises around all of those types of things and to help connect to jobs and progressive employment that gets closer and closer to their dream jobs over time. So that's another thing that we're trying to scale in a much bigger way. So I'll stop there and go back to interactive. Thank you so much. Yeah.
I just wanted to, so trauma in like Germany, you know, during the Second World War, they've done a lot of studies in the last 50 years on what works. And what they found is like the people in the concentration camps, they came out and they got into groups and they had group therapy, and it was amazing. It was like the only thing that worked to make people really healthy. And so they've shown that with trauma and this kind of trauma that you're talking about, that is the thing that works. And yet I find that in this country, talking to a lot of people about the, you know, Gabor Mate and Thomas Hubble and all these people that have already existed and have all this information, it's very hard for America to assimilate it, you know, to take it in. And I don't mean America in a bad way, but I mean that our history is just different. And we don't really, you know that much, or we don't, because we're so, what is it, entrepreneurial or capitalistic or whatever. But it's so wonderful to hear how all the stories of how this works. And it's just hard for me to find, like, I think I'm going to move to Canada soon.
That's great.
I think that's the only place I'm going to fit, because I talk about it and people can only really listen a little bit about it. But that seems to be the way. That's why I brought up just recently with the AA program. Because I have a son who's struggling, and he's 18, and it's a group right now that is struggling a lot. The boys that are 18, because they don't have the mentors. They, you know, we have Trump and we have Biden, and we don't have the strong, you know, valued mentor for these boys, and they are just all over the place. And so I'm working with the school that he goes to, and we're working on what you talk about, community, feeling safe, you know, so that he doesn't go into like, have to have mental health issues. So, and the thing about mentors, I think is so wonderful what you're saying, and I talk to the teachers and people there that are the ones that are non-reactive, not the ones that aren't, you better, the top-down approach is dying. The people that have the approach, you know, the cooperative approach, you know, those are the people that are really reaching these boys and helping them thrive. And it's just, I want to get this out there, but what I was saying about EA, Emotional Anonymous, I was in that for 45, 50 years ago. And that existed up in North Conway, New Hampshire, but now that's non-existent around. I've checked. And I would wonder, because you have the power, I have none. So I was wondering if you could look into that in the state of Vermont, to put that in with the, you know, wherever they have the AA, like even like Narcotics Anonymous. I know people have really gotten healthy by being in there. People who were really downtrodden. I mean, it seems to be that the Germans and the trauma specialists are right. The group therapy works.
I appreciate all those comments for sure. And just to dig in just a little bit more, I would give you the benefit of the doubt from like a data validation perspective that you've done the research and that it says that group therapy specifically is like an efficacious evidence-based thing. I think that's probably true. And at the same time, I think that you could take the therapy part out of that and just say the groups themselves work, and that it's about human connection. And what I've seen over and over and over, and has become only exacerbated in recent years, is we have the most polarized society probably in recent memory, maybe in memory of people, you know, in your whole life maybe, in terms of what you can agree on, who you can talk to, your ability to be in the same room and talk about issues you disagree with. And at the same time, we've used, you know, social media really as a proxy for human engagement. And that has really been a catalyst for a lot of social isolation. And so it's sort of this perfect storm where it's really difficult to talk to people in general. You're spending a lot less of your time interacting with people, and you have the impression that you have because you spend all day looking at things and sharing and liking and talking and whatever, and you just have this feeling of just things are not really going particularly well. Then that's overgirded with things you might hear about climate catastrophe and war and everything else, and it's a really tough time. And so part of what we're also trying to do is to create opportunities for people to just interact and engage in just joyful, interactive ways. So we have another small scale thing that I didn't mention that's called handwork. And that's really just, you get together once a week, people bring their knitting or their crocheting, you can draw, you can carve, whatever it is, and you just sit in the same place and just, do the same thing we did on those job sites 20 years ago, where you just space out and don't look at each other and you're working on your thing and just talk about your life informally. We could call it, an evidence-based practice. We can point to, this is intentional peer support, or using a peer recovery model of pro-social engagement to avoid social, isolation and the deleterious impacts on population-level health indicators, whatever. But just getting together and talking and forming friendships is critical. And that really, when you do distill that data down, is the most important thing in terms of health outcomes. We know that social isolation is the greatest predictor of chronic health conditions, early death, highest medical expense. And then when we talk about protective factors, that very often is like, there's just supportive people in your life that you can talk to. You have friends. A lot of people that don't have natural supports in terms of positive friends that are, modeling things that are healthy, or family that they can rely on. The groups that you can provide, the therapies, the supports, the services, those are important. But those natural supports of just growing that network is absolutely critical. So that's something that we're really trying to focus on also.
So we have 3 family members who in the last year, 2 of them have died from fentanyl overdose, and 1 of them is barely hanging on. And one of the ones who died, and one is still here, had a traveling salesman show up in their school, salesman, and when they were 13 and 15. And aside from making me completely homicidal,
Right.
when I think about these things, I don't know what are we doing? Or is your network able to deal with kids that young? I mean, there was no saving them from the time that happened.
Yeah.
We were just waiting it out.
Yeah, it's a huge
Getting
issue.
out of rehab, the whole,
Yeah. Yeah, we historically work with people who are older. There is a lot of promise in youth-focused peer support, which is under-leveraged many places. I think there's a lot of need to grow that. And I think that most of my efforts on this has really been around harm reduction itself, and this idea that, if you think back a few generations maybe, there was this idea that you could experiment with substances and that was just a normal part of life and that was going to happen. That continues to be something that happens, but your likelihood of encountering extremely lethal toxins that are tainted in those supplies is so high that initial experimentation that happens can be fatal incredibly quickly. And so this idea that you kind of dabble and then suddenly you develop a substance use disorder and it gets really bad, and then there's treatment and relapse and recovery and this whole process, and you have all this time, is really not the equation anymore. Like, it could just happen so quick. And so for that reason, we really support harm reduction focused efforts, and this idea that there's ready availability of fentanyl test kit strips and distribution of naloxone and things that support, like xylazine specific, which is a substance that naloxone doesn't work on. And this is the most controversial thing that we've done, and there's always a split room when you talk about it, but we've vigorously supported overdose prevention centers as well, with the idea that if you find epicenters of opioid-specific use of substances, and there's a high occurrence of mortality associated with that, fatal overdoses, and lack of supports, that if you create an environment that has medical oversight and support, that has been shown around the world to save lives, and that gives you the time to then engage with readiness to engage in treatment and changes in your life. So that is something that there's a real difference of opinion within the recovery community and the larger community around, but we fall very squarely in support of harm reduction for that reason. But it's a critical point. To your point about younger supports, I think there's a lot of need to expand the supports in school as well. And one of the things that we're also looking at is, when we do historically recovery coaching, all of the things that we help you with are called recovery capital. What are the healthful activities you're going to do, who you're going to connect with, how are you going to structure your life in a way that supports recovery. It turns out that recovery capital, those are the same things that we call protective factors over on the prevention side of the house. And is there really a need to wait through the lifespan to the point of acuity to then provide the things that would have helped back here too? So we want to always make those available here, but we're trying to find more ways to expand prevention-based supports as well. And I think there's a critical need to do that with youth in schools. There's also a need to find ways to make this really driven by the people that are getting that support. One of the most powerful lessons that I learned out another way was I could have all kinds of ideas about what's healthy or what's an evidence-based practice, what's going to change your life. And almost always I was totally wrong. Like one of the very first things I did was try to outlaw smoking, right? You go to the center, it's supposed to be about health. Here's the garden, here's the meal site, here's the yoga. How could we have smoking here? So I thought, you're welcome, no more smoking, great. Everyone's gonna, be happy. Everybody left instantly. We had, we had 100 people we served. Suddenly we have 5 people overnight. It's like, oh my God. And so I figured out you can't just do that. So we had to have a designated area where people could smoke and have autonomy. And, then I had, a TV in the living room, thinking people would watch, documentaries, and this would be so healthy. And people wanted to watch, like, the Night of the Living Dead and, like, The Road and zombie stuff. And we were really split about it, and we thought, just let it happen. And what we found is that when people could control the remote, you had 30 people that were watching and talking and supporting each other and forming friendships, and the show turns off and they're still helping each other and their life is better, and that's a protective factor. But I could look at a textbook and say, well, we can't have, we can't have smoking, and we can't have TV, and we can't have whatever. So we have a tendency to be very careful in our availability of resources. They come with a lot of strings and a lot of guidance of how they should be used in the community. What's the most helpful is when the community you're trying to serve can be directly involved in telling you what actually it's going to look like and adjusting and implementing it. And that's a hard lesson to learn, but I raise it because any support for youth really has to be youth driven.
So we're getting some questions online, so I'd like, since you asked a question, I'd really like to take the ones online. So this one actually, Tom, is probably more for you, from Dan Gottlieb. He shares, love what you're doing. This is probably a naive question. Dan, there are no naive questions, only great questions. Is there a specific Maslow's hierarchy among the folks who go through Dismas House? In other words, is therapy more important than stable housing, employment, money, etc.? I sometimes wonder if our limited funds might be more efficiently used to provide housing and some money for people, which might then allow people to make progress in other areas. So Will and Tom, I'd love to hear responses for both.
Yeah, a great question. I find that when people first get at Dismas House anyway, a lot of what they really want to take care of right off is the finding the employment and having some money and being able to be financially stable so that they can afford the program fee and stuff like that. And I certainly don't want to discredit the therapy. Some people, when they get there, I think they kind of dive into the therapy piece as well. It really depends on the individual, I think. For some people, the therapy is going to be the most important piece to take care of, because without that, they may not be able to function as well as they would like in society. And for other people, the therapy, I think, can be kind of put to the side for a little bit. And okay, let's get you a job, and let's get you somewhat stable, and let's build you some relationships and get you connected back with family and stuff like that. And then the therapy piece can come in. Like, all right, I'm happy about this. There's another piece of my life that I want to take care of, and that's the therapy piece. So I find that it really depends on the individual person, and sometimes trying to figure that out as staff can be tough. But it really is, that's where it really comes down to listening to the person and what are their needs, and being able to sit down and I think a lot of it is being able to let them prioritize what they really feel they need instead of us trying to prioritize what they need because what I think they need and what they think they need could be two very different things, and I've got to go with what they really think they need, because if I don't, it's not going to work.
I think that was beautifully answered. Absolutely. Yeah, it's all about that client-driven, self-empowerment-based framework for sure. The only two things I'd add really quickly are that housing first is one of those evidence-based practices that we can point to a lot of data for. And there's a shift that happened. For a long time, people thought you're not ready for housing if you're still dealing with addiction or dealing with mental health challenges or unemployment. And the data shows that you are much more likely to succeed with any of those things once you have housing. And so just making housing available as soon as possible will improve your likelihood of all those things working. So we always try to support housing first as an option. Within housing, it's complicated also because On the one hand, there are a lot of people who would love to live in a sober living environment called a recovery residence in Vermont, and we certainly don't have enough of them. We need exponentially more than we have. And at the same time, for everybody currently in recovery, there's probably 10 or 100 people dealing with substance use disorder that are not in recovery. And if we're going back to that harm reduction framework of keeping people alive and buying time for that, there's a huge need for harm reduction-based housing also that accommodates active use and provides the ready support necessary to work towards recovery over time. So if I think of the types of housing that are available, we have a critically low supply of all of them, but particularly permanent supported housing, which provides lifetime support and subsidy for people managing complex barriers and co-occurring conditions. We have almost none of that at all. So I definitely try to never dissuade from anybody wanting to create more recovery residences or more of anything, but don't forget about that part of it also. The other thing I'll add, and none of these are, the other thing I'll add is that we're spending the money one way or another. And so often when we think about what the investment should look like, we approach it from this idea that we're going to be saving money and that we need to be judicious with that savings and triage and prioritize where should the chip go on the bingo board. The most expensive systems of care that we have in place are the backstop for the system of care. When we haven't done the right things, people find themselves in incarceration, in an emergency department, on the street, and in those types of environments. Those services cost so much and the outcomes are so poor, and we work with the same people over and over and over. So it isn't the case that you can say, well, we're just not going to be providing tax dollars to support this person. What it really seems to be is that we're going to spend quite a bit more for quite a bit longer with quite a bit worse outcome than if we take maybe that same amount of money, maybe sometimes more, maybe a little bit less, to provide the housing and the supports and employment supports and the educational attainment and all those things. When you're done, someone's life is totally different, and you've used the money in a way that you can stand back and really be proud of. So, we're not at the point where we can just hospice these systems and say, oh, we can't have, incarceration facilities anymore, we can't have whatever. So it's always a both and so I encourage people to think that there really isn't an option to just spend less. We really have to embrace a willingness to support people in a way that is more holistic, that meets more global needs, because if you don't do that, you're just going to keep spending on the things that are going to produce, recidivism and overdose and, chronic health conditions and whatever. So diverting those fundings from one to the other when you can, those investments is critical. But overall, we really need to find more money, new funding sources. Other states have succeeded with that, where they've tied some of their tourism functions and some of their general economy functions to developing the systems, so it doesn't all have to come from a limited global dollar fund and a budget, where you could go in Florida and buy something in a store, and a percentage of that would go towards building permanent supported housing or reentry focused programs or whatever. They invest millions, hundreds of millions of dollars every year just tied to their economy, instead of always just that it's a tax allocation. So those pathways there are templates for those other places, and we need to expand our thinking to make that possible.
Can you does a segue kind of to or from that, just sort of speak to Portugal? In the training we learned that Portugal and Portland and the Oregon area have seen significant improvement in overdoses, saving of money through not having to do the incarceration, and instead putting that money, not doing this war against drugs thing, instead doing something more proactive in building those homes and houses and that housing rather, to facilitate that. Can you just sort of utter any statistics, or just that hit home for me? It really, like, everything you're saying makes sense, but when they actually gave me, and this place did this and this is how it turned out.
Yeah, those are good examples. I would say that the jury is out on the Portland version and the Oregon version, and what we've seen, my own take, and again, just speaking as one, not attempting to speak for a community or movement, but I don't think that when decriminalization happened in Oregon that enough money was put into the support part of that equation. And I don't think that is an example I would point to as successful as it could be. One thing they have done well there, though, is the creation of a full range of housing. So there's an organization called Central City Concern in Portland, and they provide on the one side alcohol and drug-free units, which are recovery residences that have permanent subsidy and wraparound support. And on the whole other end of their continuum, they have the non-alcohol and drug-free residencies, which are also permanently subsidized with support. So any phase of addiction that you're in, there's a stable housing place for you to go with support. you can graduate from one to another, but you never fail out of one into literal homelessness. So they don't have a situation where someone doesn't cut it in a housing environment and they're living on the street. So I think that's incredible. Portugal, I would say, is more established. And what I've heard, you know, on the law enforcement side, especially from like Johan Hari and some of those folks, is that there was a lot of resistance in law enforcement to legalization of substances. They thought it was going to drive, you know, increases in use and crime and things like that. Then you'll hear from people, like particularly in Brazil and things, who had said, I would never go back. I could never imagine going back to the way that it was. And the difference is that if you were in an alley and your friend is having an overdose event and I'm walking by on my rounds when we have our prohibition approach to substance use, you're going to try to figure it on your own. You're going to hide. You're not going to tell me. And your friend is going to die. And now, when that's not the case, you're going to run out and say, hey, this is what's going on, and I'm going to save their life. And I would never go back. And so that's something we've seen over and over. And again, there's this idea that if you look at like syringe exchange programs and things like that, they get a bad rap, but there is a tremendous correlation between those supports and recovery. And this can be the greatest catalyst for recovery over time, just keeping people alive, giving them what they need to have dignity, to give them the message that they're you know, valued, and giving them a range of options, building that relationship, giving people more, you know, protective factors and social capital and all of that, and then giving people the real option to drive what their life looks like. And over time, incredible changes happen. And at the same time, when they don't, that's not a failure. You're still giving people dignity and support and hope and keeping them alive. So, yeah.
Thank you.
Yeah, of course. Yeah.
I'm actually going to do the wrap up.
Perfect, yeah.
I can't believe how quickly an hour can go by. But our technical operator here on the Zoom has a hard stop. So I think, but if you would be willing to like sit and chat with us for a little while more, because I feel like the conversation is so wonderful. I know you probably have things to do and places to go. I don't want to get in the way of your work at all. But I want to do two things. One is thank the library for hosting us here today. But also thank you for making it the URL in the Zoom, but for anybody who wants to hear more about Will and his program, it's recoveryvermont.org, and I really encourage everyone to take a look and to become involved and support this organization as peers, volunteers, and financiers. And then I think that's it for me. And maybe one final question, Jen, before we turn it off.
It's got to be a softball question. Super easy.
Okay, fantastic, because Nora has a great one.
Great.
Nora would like to know, is there a difference between peer support and intentional peer support? She wasn't certain if the language was used interchangeably or not.
It's like the Masons and the Shriners. You don't have to use intentional peer support to do peer support, but most often you do. Vermont is basing most of its certification on intentional peer support. It's a great framework. I've been a trainer in that and a practitioner for years. I highly recommend it. But people do it differently, different places. And there are some companion tools that are also helpful in that practice.
That's a wrap. Thank you so much.
Yeah, thank you all. Thank you all so much. Really appreciate it. Thank you.